So let's talk about the amniotic fluid embolism. There are phase 1 and phase 2. In phase 1, there will be pulmonary artery vasospasm leading to pulmonary artery hypertension, and will lead to the right heart failure, hypoxia. Myocardial capillary damage will lead to the left heart failure. Pulmonary capillary damage will lead to the ARDS, and key feature is respiratory distress with decrease in oxygen and hypotension. Okay. Now phase 2, there is hemorrhagic phase. There will be massive hemorrhage, DIC. Key feature is bleeding, seizure also often present. Okay, so these were some points taken from the BNB. Okay, about the amniotic fluid embolism. Now let us talk about the mediastinal pathology. Normal mediastinum contains heart, thymus, okay, and lymph node, esophagus, and aorta, divided into compartments. Mediastinal masses, some pathologies, example lymphoma, lung cancer, abscess, can occur in any compartment, but there are common associations. For example, anterior there will be thyroid and thymic neoplasm along with teratoma, so terrible lymphoma. Okay, 40. So what are those? Thyroid, thymus neoplasm, and teratoma and terrible lymphoma. Middle, there will be esophageal cancer, metastasis, hiatal hernia, bronchogenic cyst, and posteriorly there will be neurogenic tumor, for example neurofibroma or multiple myeloma. Okay, I have written here one point from Ambush, that is neurofibroma, majority of posteromedial masses, that is 60%, is neurofibroma. Okay, so posterior mediastinal mass, 60% time it will be neurofibroma, will lead to chest pain, mass effect, cough, hoarseness, and dysphagia. Lab will be normal, and foregut cyst can be also present in the young children. Okay. Now talking about mediastinitis. As the name suggests, it is the inflammation of mediastinum, commonly due to post-operative complication of cardiothoracic procedures. Okay, pathology less than 14 days. Esophageal perforation or contiguous spread of the odontogenic or retropharyngeal infection. Chronic mediastinitis, also known as fibrosing mediastinitis, due to increase in the formation of connective tissue in the mediastinum. Obviously, in the chronic there will be fibrosis, isn't it? Histoplasma capsulotum is a common cause. Clinical feature is fever, tachycardia, leukocytosis, chest pain, and especially with cardiac procedure or external wound drainage. Okay. Now talking about what is this? Pneumomediastinum. Okay, presence of gas, usually air in the mediastinum. Black arrow, you can see over here, black arrows. These black arrows are nothing but these things, black arrows. These are the air. Okay, around the aorta. So this is aorta, and there will be black arrows will show. Black arrow is showing the air around the aorta. Red arrow shows the red arrows over here. You can see red arrows can show the air. Okay, air dissecting into the neck. Okay, this can lead to the crepitus. Can either be spontaneous due to rupture of pulmonary bleb or secondary to trauma, iatrogenic, or Bohr-Habb syndrome. Okay, so remember, Bohr-Habb syndrome is a rupture of esophagus on violent vomiting. Okay, that can lead to Bohr-Habb syndrome in alcoholics. Ruptured alveoli allow tracking of air into the mediastinum via peribronchial and perivascular sheath. Okay, clinical feature: chest pain, dyspnea, voice change, and very important finding, that is subcutaneous emphysema, and also the presence of hormone signs, that is crepitus on cardiac auscultation. Can be associated with pneumothoracis. You will see radiolucent line around the aorta or even the diaphragm. Okay, so this radiolucent will tell you air, presence of air. Okay, next page. This is about the obstructive lung disease, very important topic. So obstruction of airflow leads to the air trapping in the lungs. Airway close prematurely at at high lung volumes. So there will be increased FRC, increased residual volume, and increased total lung capacity. In PFT, you will find classical finding is decrease in FEV1, which is more than FVC. That's why there is the ratio is decreased, which is the hallmark of the obstructive lung disease. Okay, VQ mismatch can be there, and chronic hypoxic pulmonary vasoconstriction can lead to cor pulmonale. Chronic obstructive pulmonary disease includes chronic bronchitis and emphysema. Okay, now talking about chronic bronchitis. In chronic bronchitis, you will see there is wheezing, crackles, cyanosis due to hypoxemia due to shunting. Okay, cyanosis due to hypoxemia due to shunting, and dyspnea, CO2 retention, and secondary polycythemia can also be there. Remember that there can be secondary polycythemia. Now, what is the pathophysiology behind chronic bronchitis? There is hypertrophy and hyperplasia both. Remember, there is hypertrophy and hyperplasia of both mucous secretory glands in the bronchi. This will lead to the Reed index, okay, more than 50%. Normally, it is 40%, but if it exceeds 50%, then it is diagnostic for the chronic bronchitis. Okay, and what is Reed index? I already talked in the anatomy section, but again I want to repeat, is the thickness of the mucosal gland layer to the thickness of wall between epithelium and cartilage. Okay, DLCO usually normal in the case of chronic bronchitis, and you will see it will be decreased in the emphysema. Diagnostic criteria is productive cough for more than 3 months in a year for more than 2 consecutive years. Now talking about emphysema is pink puffer, barrel shaped chest, exhalation through pursed lips, increases airway pressure and prevents airway collapse. Okay, so while you are it is a actually adaptive mechanism, the patient will exhale through the pursed lip, so this will prevent the airway collapse and it will increase the airway pressure. Centri acinar can be centri acinar, which is associated with smoking frequently in upper lobes because smoke rises up, and pan acinar is associated with alpha 1 antitrypsin deficiency, which I would like to remind you that is due to autosomal codominant homozygous for the Z allele is more dangerous, and there is decrease in secretion of alpha 1 antitrypsin secondary to abnormal protein folding. Okay, remember this is very important, abnormal protein folding, which was asked in UWorld. Frequently in the lower lobes. Okay, enlargement of air spaces lead to decreased recoil, increased compliance. Okay, decreased DLCO from the destruction of the alveoli. Whenever there is alveolar wall destruction, there will be decrease in DLCO. And imbalance of proteases and antiproteases leads to increased elastase activity, which will increase the loss of elastic fibers, leading to increased lung compliance. In chest X-ray, you will find there is increase in AP diameter, flattening of diaphragm, and increased lung field lucency. Now talking about the tobacco. So tobacco increased neutrophil and macrophage activation, inactivates already low quantity of alpha 1 antitrypsin through oxidation of the crucial methionine residue. Okay, so tobacco will go and lead to the oxidation of methionine residue in alpha 1 antitrypsin, and that's why there will be decrease in the quantities of alpha 1 antitrypsin. Patient with alpha 1 antitrypsin deficiency should be counseled to avoid smoking and exposure to second-hand smoke. You see why? Because whatever available alpha 1 antitrypsin can be destroyed by the tobacco smoke. Okay, by oxidation of crucial methionine residue. Okay, very important. Now talking about asthma. In asthma, you will see there will be cough, wheezing, tachypnea, and dyspnea, hypoxemia, and decrease in inspiratory over expiratory ratio. Okay, and pulsus paradoxus and mucus plugging. Okay, and I want to add here, mucus plugging is one of the very notorious factor for the death in the asthmatic patient. Okay, mucus plugging, remember that it is very lethal. Triggers include viral upper respiratory tract infection, allergens, stress. Diagnosis supported by spirometry and methacholine challenge test. Okay, and if you talk about the pathophysiology, this I want to add something about methacholine challenge. This is highly sensitive, high negative predictive value, and it is, however, it is non-specific. Okay, so you can use it as screening because there is high sensitivity. Now talking about pathophysiology, hyperresponsive bronchi leads to reversible bronchoconstriction, smooth muscle hypertrophy, and hyperplasia. Again, here there is smooth muscle hypertrophy and hyperplasia both. As it was in the case of chronic bronchitis, if you remember, there was hyperplasia and hypertrophy of the mucus secreting glands, isn't it? Here there will be hypertrophy and hyperplasia of, yes, very good, smooth muscle, right? So smooth muscle hypertrophy and hyperplasia. Custman spirals, okay, these are said epithelium forms the hold mucus plugs, okay, hold mucus plugs. You can see in the image in the next page, I will show you. And charcoal laden crystals, that is hexagonal eosinophilic, that's why I have made this picture, hexagonal eosinophilic double pointed crystal formed from the breakdown of eosinophils in the sputum. DLCO normal or increased, very important, okay, remember this, DLCO can increase in this. Why? Because due to increased pulmonary capillary blood volume. Okay, now talking about type 1 hypersensitivity reaction. This is a type 1 hypersensitivity reactions. Other thing that you need to know about asthma, it is type 1 hypersensitivity reaction. Aspirin induced asthma is a combination of COX inhibition that leads to the leukotriene overproduction, airway constriction, okay, chronic sinusitis and nasal polyp, okay, and asthma symptoms. These symptoms are basically called SAMTO triad, okay. SAMTO triad, together they are called SAMTO triad. This airway obstruction, chronic sinusitis with nasal polyp, and asthma symptoms. So basically airway obstruction, asthma, and polyps. Now this is in short I have talked about pathophysiology of asthma. You see, initial exposure, what will happen, the allergen will be taken by the dendritic cells and Th2 will be activated. This will lead to the interleukin 5 eosinophil recruitment, but apart from that there will be B cell activation leading to the antibodies formation, which will bind with the mast cell leading to degranulation. Okay, in early phase what will happen, later in early phase there will be the activated mast cell priming, which was already primed in the initial exposure, that will get you see, that will get activated when it will encounter a antigen, okay, the same antigen. Okay, after it encountered the antigen, this histamine and histamine and leukotrienes will release, and this can cause bronchoconstriction. Apart from that, there will also be, on the late phase, you can see there is recruitment of eosinophils, which will release the major basic protein, okay. And apart from that, there will also be recruitment of neutrophils and basophils, which can lead to the further inflammation. But the main hero over here is eosinophils, which will produce the major basic protein, which will cause the further downstream damage. Okay. All right, now I will read something that I have added from other resources, okay, quickly. So the patient with COPD, okay, over here in the picture I have said that emphysematous dysfunction leads to a decreased elasticity and hyperinflation with decreasing collapsing pressure. Decreased recoil of expanded chest wall allows new equilibrium at by increasing the FRC. Yes, this is very important again. So there will be new equilibrium at new FRC level. The patient with COPD developed a decrease in respiratory rate as a result of oxygen supplementation. So what is this all about? Oxygen has a minimal effect on respiratory drive unless the arterial pressure of oxygen drops below 60 to 70 mm. Therefore, arterial partial pressure of carbon dioxide is the major stimulator of respiration in healthy individual. However, patients with long-standing COPD have decreased sensitivity towards the PaCO2. Remember, this is very important line. That's why I have highlighted. See, on long-standing COPD, the patient will rely on the PaCO2 level PaO2 level, because it is insensitive to the PaCO2. Okay, due to chronic CO2 retention. Are you getting me? So therefore, PaCO2 becomes the major hero of respiratory drive, stimulation of respiratory drive in the cases of COPD. Now, if you take a patient and you start giving high dose, high pressure ventilation with pure oxygen, then it can cause hypoventilation. The depth and rate of respiration are controlled by the medullary respiratory center based on the input from the central, peripheral, and airway mechanoreceptors. Peripheral chemoreceptors found in the carotid and aortic bodies are the primary site for the for sensing the PaO2 and are stimulated by hypoxemia. When supplemental oxygen is administered, the rapid rise in PaO2 can reduce the peripheral chemoreceptor stimulation and decrease the respiratory rate. And this was what I was talking about in the case of chronic COPD patient. You should be very careful before supplying oxygen. Now, central chemoreceptor located in the medulla, more involved in the respiratory response to hypercapnia than hypoxia. Pulmonary stretch receptor include myelinated and unmyelinated C fibers, okay, in the lungs and airways. These receptors regulate the duration of inspiration depending upon the degree of lung distension. This is called Herring-Brewer reflex. Apart from that, I want to add one more thing, that cigarette smoke and how does the cigarette smoke affect the patient of COPD. It will basically lead to the epithelial cell dysfunction and macrophage stimulation. This macrophage stimulation will activate neutrophils, and together with neutrophils, macrophage and neutrophil both will produce proteases, neutrophil elastase and membrane metalloproteases. Okay, this will lead to the mucus hypersecretion and damages. Okay. Cytokine release also cause CD8 T cell activation, which can further destroy the alveoli. In addition, inflammatory cells shows impaired ability to phagocytose bacterial pathogens. Okay. So basically, cigarette smoking can cause the inability to the inflammatory cell to phagocytose bacterial pathogen, which will lead to the pneumonia. Especially if you remember in the Legionella, in the chronic smoker there is a high risk for causing Legionella, maybe because this was the reason neutrophil was not able to neutralize the bacteria. Okay, in the next chapter we will discuss about the atelectasis. Okay, thank you.